We are going to get started, all right? So we have Dr. Rick Harris today. This is MS NeuroTV. It's a virtual program we've been doing for quite some time. My name, for those that don't know, those that are online and have never seen me before, well, this is me. Yep, you got it. That's a younger version, though, that you're looking at. All right, this program, this event has been this entire series. It's sponsored by MS Views and News. It's not really sponsored by us. We are it. It's an MS Views and News event. Today, we are featuring Dr. Rick Harris. And Dr. Rick Harris, well, he's got this great talk on living in the moment, all right? And if you've never heard the song Living in the Moment, I mean, it's part of his entire talk, but it's pretty cool. It's very nice to listen to. And you know, it helps you with a lot of what you want to do, you know, with wellness, with your own mindfulness. And that's a lot of what Dr. Harris is going to speak about. So it's the challenges that MS patients encounter and how to cope with it, and things to do and feel better about yourselves. So with that, I'm going to let Dr. Rick Harris take the mic. Thank you very much, and I'll see you back in 40 minutes. Dr. Harris?
I'm really honored to be able to share this concept with you all as living in the present. If I had one gift to give you and everyone, and that would be this skill that we're going to talk about at the end of my talk, and I'm hoping that I make sure and leave enough time to get there. Living in the present is really a coping strategy. Not only a coping strategy in dealing with MS, but also in dealing with life's stressors. But before we go into life stressors, what I wanted to do is first identify and talk a little bit about the challenges that MS patients experience. Can I have the next slide? When we look at any chronic illness, we can break down the challenges into four particular areas. There's the biological challenge, psychological challenge, environmental challenge, and for some of us, there's a spiritual challenge that we all face when we're having to deal with any chronic illness, and particularly MS. And if you can see the way that this slide is conceptualized, that there's a complex interaction between all of these factors. And they interact and they affect each and every one. Each one affects each one. Let's first take a look at, next slide, please. Let's first take a look at the psychological challenges that we may face as an MS patient. Next slide. So we certainly know that MS patients are challenged by what we call mood disorders. A mood disorder is defined as a sustained or pervasive emotion that really affects our perception of self, perception of others, and the world we see. A mood disorder can be depression and/or anxiety. Most of the MS research has been focused on depression. However, anxiety is also prevalent in the face of dealing with MS. Next slide, please. So what is depression? You know, so often we use this term, well, I'm depressed, okay? We use the term in the vernacular, but what is the real difference between depression and what we might call sadness or grief? When we look at depression, we look at basically clinically a 2-week period. And for the 2-week period, there has to be or there is experienced a number of these symptoms. Obviously, depressed mood or dysphoria, and it's experienced most of the day, nearly every day. Marked diminished interest or pleasure in all or almost all activities, most of the day or nearly every day. We also see with depression significant weight loss when we're not dieting, or in some instances, weight gain or decrease or increase in appetite. It's not uncommon for people that are experiencing depression to have what we call carbohydrate craving, a craving for sugars or chocolate. And in some ways, that craving for chocolate can be considered an antidepressant because it has L-tryptophan, which is a precursor to serotonin, which tends to be lacking in individuals that have a biological depression. Insomnia or hypersomnia. And some people who are depressed can't sleep. They may have difficulty falling asleep. They may have what we call early morning awakening, which is we get up, 3 or 4 o'clock in the morning and we can't fall back to sleep. Or for some of the people, they're hypersomnic, meaning that they just want to sleep all the time. We also see in depression a fatigue or loss of energy nearly every day. And notice how I keep saying nearly every day. Next slide. It's not uncommon for the depressed individual to experience feelings of worthlessness, excessive guilt, inappropriate guilt nearly every day. There's also a sense of hopelessness, worthlessness, helplessness, hopelessness. We see a diminished ability to think or concentrate, or indecisiveness, with a little tongue-tied there, nearly every day. And it's not uncommon to see recurrent thoughts of death when someone is depressed. Next slide. So we just outlined the symptoms of depression. We recognize how that's different than just feelings of sadness. Those symptoms have to be prevalent nearly every day for a period of 2 weeks. But how prevalent is depression in the MS population? When we look at that criteria I just shared with you, we see that depression has prevalent rates in the MS population from 25% to 54%. 50% of all MS patients will report one significant period of depression during the course of their illness. Remember those symptoms I shared with you? 50% of all MS patients will report having one episode of depression. When we look at the rates in the general population, we see that the disorders are more common in MS than in other disease that are associated with similar rates of disability, such as arthritis, a spinal cord injury, muscular dystrophy. MS patients have significantly more depressive episodes than patients with the above disease. There's higher rates of suicide and self-harm among depression. The sad part of this is it often goes unrecognized in the MS patient. Why? Because so often We don't look at that model that I shared with you about that complex interaction. And the focus with MS patients tends to be on what? What's going on physically? What's going on medically? You all have more information now than most of your treaters. You now have that information to share with your physician if in any way you sense that you have those symptoms we talked about. When we look at the etiology of depression, it's multifactorial. There's very little conclusive evidence to explain why depression occurs more frequently in MS patients compared to other chronic illnesses and neurological disorders. Pay attention to that. The jury's out. We don't know why the incidence and the prevalence is higher among MS patients than the other chronic illnesses. Can I have the next slide, please, Bill? So another mood disorder that I find in my clinical practice plays even a more significant role in MS and other patients that experience chronic illness. The research indicates that anxiety, again, is 16 to 48% of MS patients will experience anxiety. Often noted along the first symptom of MS is anxiety. Although the person might not even know they have MS. But when your body you start to have, vague symptoms or symptoms, what is the first reaction that is a normal reaction? Is we start to experience anxiety. And we're going to talk about how to change that anxiety, how to change that thinking, what we can do to manage that anxiety. And of course, anxiety is an understandable emotion linked to fear. I also talk about that when there's someone that may experience panic attacks. If we really look at panic attacks, it is actually the fear of those fearful symptoms. And as with depression, it can be due to the diagnosis or the symptoms of the anxiety may come from certain strategically occurring MS lesions. What's important, and again, to recognize it can be treated effectively. But what's important to extrapolate, to take a look at the symptoms of depression, anxiety, and extrapolate them from the MS symptomatology, because there's some co-occurring symptoms. The fatigue, the difficulty concentrating are also common symptoms of MS. So it becomes important that we're able to differentiate those symptoms so that we treat either the anxiety of depression. Next slide, please, Bill. Next slide. Thank you. So when we think about anxiety, what is it? We talked about the symptoms of depression, but what are the symptoms of anxiety? It's interesting. The period of experiencing what we call generalized anxiety is a little longer than the depression. It has to occur for 6 months to get a formal diagnosis. I'm not here telling you to live with your anxiety for 6 months, but to get a formal diagnosis, it's 6 months. So it's the presence of excessive anxiety and worry about a variety of topics, events, or activities. excessive anxiety and worry about a variety of topics, events, or activities. Not a specific event or a specific topic. For example, when I heard that we're going to be on air in a minute, my heart started to race a little bit. I was feeling a little anxious. That's not an anxiety disorder. That's a normal reaction to a situation. The worry, and that seems to be the core of when we think about anxiety, is when we really drill it down, that worry. And you think about this, whenever we have a chronic illness, it's normal to worry about what's the course of the disease, what's my day, what's my tomorrow going to be like. The worry is experienced as very challenging to control. Normal reaction to a chronic illness. If it persists, it results in the anxiety. The anxiety and worry were associated with some of the following physical or cognitive symptoms: edginess, restlessness, tiring easily, more fatigued than usual, impaired concentration, or feeling as though the mind goes blank, irritability, feeling on edge, right? And people may not notice it, but you feel it. It's that uncomfortableness. Increased muscle aches or soreness. Typically with anxiety, we have difficulty falling asleep, staying asleep, restlessness at night. We never feel as if we get into that deep sleep either. Next slide, please. We also experience symptoms such as sweating, nausea, or gastric problems, such as diarrhea. The anxiety or worry or associated symptoms make it really hard to carry out day-to-day activities and responsibilities. They can cause problems in relationship, at work, or in other important areas. And the symptoms are not related to any other medical condition. Okay? They're not a side effect or an effect of substances, including prescription medication. There are some prescription medications that can cause anxiety. Some thyroid conditions can cause anxiety. Use alcohol or recreational drugs. This is just symptoms of anxiety. And they're not explained, but by a different mental disorder. So often, I'm asked, what's the difference between anxiety and fear? Right? Fear is an actual threat to our own well-being. We hear about, the fight or flight syndrome. If there was a loud roar behind me, and there was a grizzly bear that broke through my door, I would experience some of the same symptoms that we talked about. My heart would race. I might have some difficulty breathing. I would sweat. There was a real threat. My body's responding to get me ready to either fight the grizzly bear or to flee. All of those symptoms serve a purpose. The difference between fear and anxiety is an actual threat, and with anxiety, it is a perceived threat. When I signed in prior to this, I perceived there was a threat. You all might not like what I have to say. You might not like me. That's a perceived threat. I perceived that you might hurt me. Not a real threat. That's the difference between anxiety and fear. This is interesting. What's the difference between anxiety and excitement? We have a lot of the similar symptoms when we're excited, right? The difference between anxiety and excitement is our thinking. And we're going to talk about that and what we can do to change our anxiety. But think about that. I'm in line to go do a roller coaster, right? And I'm with a friend, and he's sitting there, and his heart's racing, and he's restless, right? And he says, "Oh my God, what if that thing falls down? What if I fall out?" He is experiencing anxiety. On the other hand, I might be looking at I can't wait to go on it. That's such a cool ride. It's going to be thrilling. My body responds the same way. It's a different perception, a different thought. By the time I close today, you're going to have the skill to help you change your thinking about anxiety. Certainly, next slide. Certainly, we know that with MS. I'm going to slide through this a little bit. Certainly, we know that there's cognitive changes, and they occur in some degree in 43 to 65% with MS. The research suggests that there is this neurobiological process. Remember my circles? There's a biological process that can contribute to the cognitive changes. Conventional MRI technology is not sensitive enough to detect those cognitive changes. We experience them, but we're not necessarily able to pick them up on MRIs. What do MRIs look at? Structure, but not function. Cognitive changes are functional changes. There may be a structural, but not necessarily. 80% of MS patients are mildly affected by cognitive changes. It can be a great source of stress for individuals with MS to recognize they're experiencing cognitive decline. It can also go back, that cognitive decline can also cause us some anxiety when we start to worry about the course of the disease. What's interesting is research has found that the way a person copes with this realization may provide a stronger association with depressive symptoms than actual physiological process. Coping strategies can have an impact. And again, I'm going to make sure that we have time to go over some of those coping strategies. Next slide. Most commonly reported difficulties are memory, attention, planning, problem solving, information processing, word finding, visual spatial problems. And they can fluctuate. The problem with cognitive functioning, they may not be apparent on bedside testing. This is probably the most stigma we experience when we have MS, is I'm losing my cognitive abilities. So we may not share that with family, friends, or even our physician. Next slide. Obviously, fatigue is another challenge that one faces with MS. 80% of all MS patients will experience severe fatigue. 100% will experience fatigue at some point in their disease course. Next slide, please. Certainly, our environment plays an impact on our psychological well-being. Remember this, the circles? We know that 27%, next slide, of MS patients have loss of personal income, 46% impact, and I'm sorry, you see me looking my watch because I'm trying to pace, I'm trying to be present so that I can pace myself and we can get to some skills. So needless to say that MS does impact our own environment. And not only that, our environment can impact our emotional, psychological well-being. Next slide. Let's move on. Next slide, please. Next, thank you. Let's just talk about treatment, and then we're going to talk about coping strategies. We know that MS patients are not adequately treated for depression, partly a lack of understanding. Medication's not the only way to treat depression. There are some new advances. Transcranial magnetic stimulation can be helpful. Question we always hear is, how do I know if medication is appropriate? You need to consult a mental health professional, someone like myself, that can help determine if there's a biological basis to that depression, if medication is necessary. Research says a combination of medication, talk therapy, and we know that generally uses a combination of addressing the problems and the changes in what's going on with you. Individual therapeutic interventions can be extremely helpful in the treatment of depression. All right, next slide. So let's talk about what you can do. This is Rick's How to Do It manual, my do-it-yourself, DIY manual. The first thing to take a look at is how you are coping. It's important to recognize typically that there are two types of coping strategies. And they can provide a strong indication of how well you're going to cope and will go on to develop depressive symptoms, anxiety, or not. We can classify them in two styles of coping. One, problem-focused, where there is an active attempt to change the stressful situation. Problem-focused, what can I do about it? Or emotion-focused, where there tends to be an avoidance of the unpleasant emotions. Which one do you think is more productive and leads to less depression, less anxiety? The person employing emotion-focusing coping strategy may experience the negative thinking associated with that depression, whereas a person who uses problem-focusing may seek more information and more interpersonal and social control. There is a strong relationship perception. So I want to be real clear. you all need to take a look at how you cope. Are you emotionally focused, emotionally reactive, or am I problem focused? Am I, oh my God, what's happening to me? Or am I, what can I do about it? Right? So I remember several years back, I was involved with a study of patients that were diagnosed with cancer. And the hypothesis was that the diagnosis of cancer would be a traumatic event. Right? I mean, we wouldn't, all of us would understand that. But when we looked at the data, we found there was a subset of people that saw their cancer diagnosis as an opportunity to reprioritize their life. When we delved deeper into that, they were people that employed the problem-solving coping strategy. The ones that were more affected by the trauma were the emotionally focused. Okay? There's a strong relationship between illness perception, quality of life, and psychological diagnosis to MS. If I start to think about what I can't do rather than what I can do, then it's going to be impacting me more. So perception is really, really important. So let's take a look at now what if thinking. Thank you. So when we stop to think about one of this, I think the most important skill we can learn is to what I call being here now, or as the title of this talk is living in the present. So one of the most common things we do in life when we're faced with a chronic illness, not even, just in general, is we employ what if thinking. What if my disease gets worse? What if I can't work? What if I can't function? What if it rains tomorrow? Right? What if I get COVID? I'm willing to bet to you that one of the universal two words that we as Americans say is what if. Now understand, the minute you hear the words what if, you're causing yourself anxiety in the moment. So how do we change that? Time. Time is an abstract concept. We invented time to coordinate events. I'm going to say to you, I'll see you next month at the next webinar. Time is to coordinate events. The only thing that truly exists in time is this moment. You can hear me, you can see me, you can experience what's around you. It's tangible. The only thing that exists in time is this moment. If that's the case, one must ask ourselves, does the past exist? No, it's gone. Does yesterday exist? No, it's gone. Does this morning exist? No, it's gone. Now, I might have a memory, but it doesn't really exist. Does the future exist? It hasn't happened yet. It has not happened yet. The only thing that exists in time. Now stop for a minute and think about that. If the past doesn't exist and the future doesn't exist, does one have control of the past? No, we don't. The more difficult question one must ask is, do we have any control over the future? We'd like to believe we do, but the truth is none of us have any control of the future. Plans and goals are important, but they are our subjective reality. They're what we'd like to see happen. The only thing you and I have control over is this very moment. So we need to be mindful when we hear ourselves say, oh, I should have done that, or I could have done that, or I should have taken better of myself when I was, in my early 20s, or I could have eaten better. We need to realize I've just taken myself out of this moment that I have control over and put myself in the past. And I caused myself guilt and shame that we're not experiencing in the present. The most common two words are what if. We need to be mindful of when we hear those words, what if, I'm putting myself out in the future and I'm causing myself anxiety in the moment that I might not necessarily have. So we need to realize living in the moment gives me control of my life. Living in the past causes me guilt and shame. Living in the future causes me anxieties and fear. Moment to moment, being present, living in the present. So we need to be mindful when we hear those words. I wish I had another slide because there's a little technique that I have developed to help people implement this. And it's what I call the RIC method. The R stands for recognize. Recognize your own thinking. Recognize coulda, shoulda, woulda thinking. Recognize the what if thinking. Insight, I. Am I in the past or in the future? The C stands for confront those thoughts and say to yourself, stop. What can I do about that now? If I can do something, I do it. If not, I say I need to be present. I need to be here now. R-I-C. And the K is you gotta keep doing this over and over. I think, Stu, I'm good. Are we ready for questions?
I'm living in the moment. I was right here, ready for you.
Tell you a funny story that happened to Stu and I before we started. He said, Rick, where's your slides? What are you going to talk about? I go, I don't have any slides ready. I'm living in the moment. This was going to be an existential presentation. And then he so accurately informed me that some people need to be able to read So in 10 minutes, I developed enough slides for this presentation. So
Right. Well, fortunately, you had the slides. I think we've seen this in the past from you, but under different topics, and it may have been just under depression and coping. But yeah, this is definitely worked out, and I'm glad it did because I think that many people should benefit from hearing about the anxiety, hearing from the depression, and so on. So for anybody online, if you have any questions to ask, please type them in. All right. You could go to that toolbar, like I said earlier. I haven't even checked to see. I was so involved with what Dr. Harris was speaking about. I didn't even check to see if anybody said any questions. All right. But yes, if you have any questions, please type them in. In the meantime, I do have a few that I'll go over. And if not, well, that was a great topic that Dr. Harris was speaking about. So first thing I want to ask you, and it's something that I've been hearing a lot about, and it's about that TMS therapy and how and what it's being used for with MS patients.
So, before we went on air, I shared this with Stu. About 2 months ago, we added TMS treatment to the practice. Now, the FDA only has approved TMS for the treatment of depression and for obsessive compulsive disorder, which is a subtype of anxiety. So there is some research, and we talked about this, that we've seen that TMS can help with the symptoms of MS. Transcranial magnetics, well, let me go back. So when we take, I find this fascinating. Let's say we find that you are a candidate for antidepressant medication, right? When you take an antidepressant medication, you take it orally, right? We can't just mind meld it. When you take a medication like that, it goes through your whole system. And we hope that the majority of the medication crosses what we call the brain-blood barrier and affects the brain so that you can respond to the medication. But it also goes through the whole system. Consequently, you see people experience side effects to antidepressant medication, right? So people that have taken antidepressant medication can experience side effects. The statistics are insane. 24% of patients, only 24%, will respond to first trial of antidepressant medication. And if the first one doesn't work, it exponentially decreases. Okay? So what transcranial magnetic stimulation does, it is a non-invasive treatment in which a magnetic coil is placed on what's called the prefrontal cortex, premotor cortex, which is an area associated with some of the deep structures of the brain that are associated with depression. And a magnetic pulse, just like an MRI, not quite as intense, is released. Magnetic coil, magnetic pulses. When you add magnetic coil or magnetic stimulation to an electrical current, it increases the current. It's called Faraday's principle. So what you're literally doing is increasing that electrical activity to the areas of the brain that are associated with depression. In our first 8 weeks of treatment, we've been treating people who have had treatment refractory depression, meaning they've been tried on at least 4 types of medication with no success or bad side effects. We're seeing remarkable results. The treatment is 18-20 minutes daily for a course of 36 sessions. I can't tell you, now, Stu knows that I was a former executive director of a neuroscience center. I've done some research in the biological causes of depression, measured electrical activity of the brain. This is the most promising treatment I have seen. We're real excited about this. I don't know yet, Stu, the research on MS. I haven't, dived into that quite yet.
Okay. I have other questions for you. All right. A person wants to know if you have any spiritual aspects you would like to add into everything that you were speaking about concerning MS.
You did see that the fourth circle was spiritual. We know that people that have a spiritual belief, I'm not talking about religion. Okay, certainly if you are have a religious belief or you follow a particular religion and that is your spiritual belief, right? But we do know that people that have a spiritual basis to their lives, that they progress better, less affected by stressors in their lives. And it doesn't have to be, again, doesn't have to be a religion. It could just be a belief in a higher power and a belief in yourself, but a spiritual basis.
Okay, thank you. All right, another person is asking, can ECT help or harm anxiety and depression in MS patients?
So let me explain to you what ECT is. ECT is electroconvulsive therapy. It is literally putting electrical current in the brain to cause a seizure. It is done with anesthesia, and you literally go into a seizure. When you have a seizure, the brain releases all of these neurotransmitters and neurochemicals. That's why you have a seizure. Those people that suffer epilepsy, there's such an instability of brain functioning, all the chemicals get released. ECT historically has been used as a last resort for patients that do not respond to medication. I will say to you that transcranial magnetic stimulation is a better way to go. I don't know if it's contraindicated for MS patients too or not.
Okay, thank you for that.
But it's not used for anxiety. It's used for what we call treatment refractory depression.
Okay, thank you for that. All right, next, the person is asking, is there information or documentation we can give to family members about the importance of understanding the person living with MS?
You know what? I have a resource. I can't tell you. Bring your family members to these seminars.
That's right.
Bring them to the symposium. I do a talk once in a while of MS and families, right? Education, education, education. Now, the most important thing is for you to be open and honest with your family members. Absolutely. But I can't tell you how important MS Views and News is and disseminating information and helping families cope and deal.
So easily to say, though, they could go onto our YouTube channel and find this. All right. It's a lot easier, to do that. And they could see the video that was made, the recording that we had made with you speaking about this subject. So whoever would like to know this, please send an email to me directly. And you do have my email address, because after all, that's how you found out about these programs, is through my email address. All right. Send an email to me and I will send the YouTube link to you, so that way you can easily get back online and see it. I cannot put it on here right now because I would have to first look for it on the YouTube channel, and that would cause me to be out of the moment, and I need to be in the moment.
So that talk was archived? I didn't realize that.
Every one of them are archived. Every single one.
Oh, that's awesome.
Okay.
Awesome.
All right. See that? So he was not in the moment when I told him that it was being video recorded and archived on our YouTube channel. So
I was in the moment, but see, that's in the past. I'm so present-centered, I didn't go back there.
yeah, I understand that, but some people just keep it in. Some people just keep it in their thoughts that we have a YouTube channel and everything goes on there. All right, I'm not going to be bashing Dr. Harris. I know him too well, and that's why this is happening. Okay, so we could have fun with this going back and forth, but we won't do that to you tonight. So let me get back to some of the questions. So a person is writing: is TMS ever or usually combined with an oral antidepressant?
So yes, it's not combined, but if you come to TMS, we want you to stay on the medication. Why? I don't want any brain activity to change while we do the TMS. After one completes the TMS 36 sessions, we can start to look at weaning someone off medication. Okay, but we don't want any changes. We don't want changes in diet. We don't want changes in nutrition, etc. When you go through TMS, we want to keep all the variables the same. So if you're on meds, you stay on meds. If you're not on meds, we're not introducing meds. Okay, but every one of our patients that have gone through TMS come to us on at least one antidepressant medication.
Great,
and most often, it's not working. That's why they come to us.
Okay, next, thank you for that. A person that lives in Canada is asking a question, but this question is probably for everybody anywhere. So where is there a list of where people could get TMS therapy, whether or not you have multiple sclerosis?
So you can, you just can Google TMS near me. You can also go to the equipment we use is called NeuroStar. NeuroStar has been around a really long time. The research is really good on NeuroStar, and they have a national website with a list of all their providers. It's NeuroStar.
Okay, great. Thank you for that. All right, next. There are a lot of people I see online tonight that I don't recognize the names, so I just want to let you know who I am. I'm Stuart Schlossman, president and founder of MS Views and News. I, too, am an MS patient, and that is why I do all the things that I am doing, running around the country, providing educational programs. So for those that might be online or might know somebody in South Dakota, please help us. We are doing events in Rapid City and in Sioux Falls in the month of August, all right? And we do need help getting the word out about that, as well as a small town in West Virginia called Huntington, okay? And we will be there as well in the middle of August. So, we are doing 6 live events on the road in August, and the other ones are, more to we have great databases in the area. But if you do know anybody in those other regions, have them reach out to us, because we are going there with excellent doctors and speakers and patient advocates and a lot more. So it's going to be a hell of a trip going there. All right, let me get back to the questions, all right? So there's a person named Jane asking, could you please go over RIK again? I'd appreciate it. It was helpful. Oh, my gosh. God, you're really swelling this guy's head, though.
Thank you so much for that. No.
So wait. Before you get into that, though, Jane, like I was saying before, every one of our events are recorded and put onto our YouTube channel. You didn't have a chance to write it down. I see that, all right? But you don't have to, all right? This will be on our YouTube channel in about a week, all right? And we'll send out information at that time for everybody that needs to have it. And you will know when this program will be on the YouTube channel, so you can watch it again and again and again and again, and you don't have to write anything down, okay? All right, Rick, take it away. Rick, Dr. Harris, please.
So Jane, you know, I've been doing this a really long time. I've been in practice for 40 years, and I started to think about what is the steps to change? What is it I'm clearly trying to help in the therapeutic process my patients change? What are the steps? And I came up with that little acronym, RIC. The first is R, recognize. Recognize, when we talked about being in the present, the thinking. The R stands for recognize, okay? Need to recognize my what if thinking. I need to recognize my coulda, woulda thinking, right? The I stands for insight. Insight into I'm either out in the future, what if, or in the past, coulda, woulda thinking. The C stands for confronting that, to challenging that thinking, to be able to say to yourself, stop, wait a minute. I don't have control of the future. I don't have control of the past. I need to stay present. The K stands for you got to keep doing this over and over and over again. Yeah.
Okay. All right. Thank you for all that. And let me get back to some other questions. All right. First off, we have how to get a person to recognize real anxiety or real depression. I know you spoke about this, and you know, there are people living with MS, and everybody that was online tonight, they should now be able to interpret what you were just saying and be able to use it for themselves. But how do we get everybody else that's out there that hasn't heard this or who do not hear this from their doctor? How do we get them the information? I mean, are the doctors, are the other psychologists talking about it as you have?
I mean, most mental health professionals are really trained in helping doing what we call differential diagnosing, right? You know, one of the things that I do is if you came to my practice, you do a pretty comprehensive assessment. I'm going to take a little questionnaire on the symptoms of anxiety, on depression, on cognitive functioning, and on personality functioning. So we have tools on our toolbox that help us do the differential diagnosing. I'm not sure that answered the question, but I do know that even online, not that I really trust a lot of that, but it's a good way just to take a look at, there's questions on anxiety or surveys on anxiety and depression online as well. You know,
Okay,
but
thank you for that. Yeah.
Best thing to do is consult a mental health professional.
Okay, thank you. Next, the person writes, when looking for a psychologist, should one look for someone who is certified in CBT or DBT, which you'll have to explain what that is to people, to help with anxiety and depression?
So CBT is a form of therapy called cognitive behavioral therapy. D is dialectic behavioral therapy. I'm not sure. So the association, the Anxiety Association of America, says that the best form of treatment for anxiety disorder is cognitive behavioral therapy. and that is learning how to change your thinking, right? And that's what we were doing with the staying in the present. When it comes to depression, it is a combination of therapy and maybe medication if it's a biological depression. I want to also point out something that I failed to mention. When we look at anxiety, we know that people that experience anxiety disorders, their baseline of arousal, that sympathetic nervous system compared to what I've come to recognize the typical person, is a little higher, right? So when something happens that triggers that anxiety, they have a Ferrari and they go from here to here. So there's another treatment called neurofeedback that is literally training the brain and that central nervous system to be calmer. We find that when we're treating anxiety disorders, the most effective treatment is lowering that baseline with neurofeedback and the cognitive piece that we talked about. So it really depends on the disorder. There's not one size fits all.
Okay, great. Thank you for that. All right, next, Jane, if you have any more to ask him, just keep on typing away, okay? It would be great to go back and forth with, or whoever asked that question. But there is Jane who just said, thank you for going over RIK. Please come to Central and Western Kansas. We are underserved and need your expertise. In the meantime, do you have a book with these ideas?
I don't, but I am archived.
That's right, you are archived, exactly. All right, next, from a medical professional. I'm not going to say who she is or what she is or what she does in the industry, but I'll just tell you her question. Question for Dr. Harris. What if you have MS plus cognitive issues or ADHD or anxiety, depression, autism, etc.? What do you do first?
So one of the things that becomes real important is I would recommend, okay, a very comprehensive evaluation. If there is cognitive deficits, we want to do a neuropsych. Let's see what those are. If there's attention deficit disorder, let's look at that. We'll take a test of variables of attention. If there's someone on the autism spectrum, let's measure that and then the degree. Then we will sit down and develop a treatment plan based on the symptoms and the hierarchy of symptoms that that person may be experiencing and wanting some symptom relief from. Some of our interventions, right, can treat the co-occurring disorders. A co-occurring disorder is a disorder that exists side by side. So for example, let's say we have some anxiety and attention deficit disorder. We may integrate, or even autism. Autism is a brain dysregulation as well. We may integrate the talk cognitive behavioral therapy with a neurofeedback. Because the neurofeedback, if you would, attention deficit disorder is a dysregulation of the arousal system. Autism is an overstimulated brain, right? So if we can improve brain functioning through our intervention of neurofeedback, then we can capture. But it is something that I sit down with patients and we talk about together once we know the degree and severity of the various co-occurring disorders.
Okay, thank you for that answer. Next, we have Rhonda. Rhonda asks, any tricks to expand the length of time brain function works? Mine is approximately 4 hours, primarily in the mornings.
Any way to extend?
how brain function works.
Yeah, I mean, just keep using it.
Push.
There are some supplements. One of the ones that I know is omega-3s are really helpful in brain functioning. We recommend omega-3s for our attention deficit disorder patients. But Ron, I think just keep using that brain, man.
Okay, thank you. All right, we're out of questions. So we are going to wrap things up. Dr. Harris, I want to thank you for being online with us tonight. For everybody in attendance, I want to thank you for being here tonight. Please know that next week we have Mental Wellness Chat, which is our series that's been going on for a long time. We also have our second part of a program that we were doing on specialty pharmacy and what you need to know to help you get your medications and keep them. All right. So, that is something that you want to tune in with us for. And if you don't know what to look for, please just go to our website, msviewsandnews.org, and it's all there. Okay. It's all there, plus all of our in-person events that are coming up over the next several months. In fact, through the end of the year, everything is listed on the website. Okay. Thank you, everybody. Have a great night. Toodles.
Thank you.